Muted, and for the sake of the live stream today, if you will turn off your cameras, that will help with our live stream capabilities and the presentation. Thank you. Well, good morning and welcome. Welcome to our fourth community conversation on the community health rankings. We're returning after a year hiatus, and we're very excited to be back with all of you. My name is Brett Martin. I serve as the chair of Heartland Healthy Neighborhoods, and it's a pleasure to serve in that position and a pleasure to serve the community. We've got a great event planned today. So for everyone who RSVP'd, you should have received an email on Friday with our agenda for the day and 2 handouts and worksheets for the day. If you did not pre-register, agendas and handouts are being shared in the chat. Additionally, today's presentation is being recorded and all slides will be shared out with participants later in the week. We're also very excited to have Sarah O'Keefe with us. Sarah is a graphic recorder with KU's Center for Public Partnerships and Research. She'll be doing visual note taking on key points from the meeting. And so those will be shared out as well after the meeting. You're welcome to follow along by pinning her if you wish to be able to see those during the presentation. As we said, all of her work will be shared out on our social media platforms and will be integrated into our community health needs assessment final report that will be published later this year. Again, thank you all for coming and for being a part of this today. Just a reminder to keep yourselves muted and to turn off your cameras in order to best facilitate the live stream. And with that, I want to go ahead and get started. So I want to introduce to you Charlie Hunt. Charlie is a senior analyst with the Kansas Health Institute here in Topeka. Charlie focuses on improving public health systems through research, development, and dissemination of tools and best practices. Charlie's going to start us off today with an overview of the 2021 county health rankings. So Charlie, thanks for being with us today.
All right. Thank you very much. Can you hear me okay? Great. All right. Well, I'm going to just provide a very quick overview of the county health rankings for 2021. And we'll talk a little bit about some of the trends. If you have questions about anything that I have today and you want to follow up with me later when the materials are shared out, my email address will be included on my slides. So please feel free to get back to me. I'd like to start, first of all, with just a general overview of the county health rankings model. I know that you all received a copy of the report for Shawnee County that Kansas Health Institute compiles. We do one of those for every county in the state each year. We've been doing this for several years now as the state lead for the county health rankings. But I want to kind of orient you to the county health rankings model. And if you're interested in more details, the slides will also have a reference for this model, so you can go take a look at the county health rankings page and really dive into the details. But it's important to note that unlike some other ranking systems, the county health rankings does not have a single ranking. It's actually 2 different rankings. One is for health outcomes, and the other one is for health factors. The health outcomes the health outcome ranking is calculated using 5 different measures. One dealing with the length of life, and that's the years of potential life loss. And we're going to talk about that in just a little bit. And then there are 4 measures around quality of life. And the health outcomes ranking is really designed to answer the question of how healthy are community members in a county now. The other measures, the other 30 measures, at least for 2021, are the health factors. And you can see that they're divided up between things like health behaviors, clinical care, social and economic factors, and the physical environment. And then those are further divided up into each of the individual measure categories. The health factors ranking and measures are designed to answer the question, what are the opportunities for community members to be healthy in the future? So it speaks more to those things that are modifiable, the communities can act on to help with their community being more healthy. Now, the other thing that I want to note is that if you look at the model, you'll see that there are percentages listed. So length of life, 50%, quality of life, 50%, healthy behaviors, 30%, and so on. Those are the weights that are applied to these measures that help determine what the rankings should be. And these are based on a lot of research over the years that have helped us determine what is the relative contribution to each of these measures, each of these factors in how healthy a person is. There are lots of different models, and the percentages will vary a little bit. This one happens to be from an organization called determinantsofhealth.org. And I like it because there are a lot of details here. And so you'll see the percentages vary just a little bit. But I would encourage you to go and take a look at that and really dive into the reasons why these weights are given like they are for these different measures. So if you're interested in how the rankings are actually calculated, there's a couple of resources for you. One is we actually did a convening here at KHI a few weeks ago on ranking systems, and I dive into the calculation of those rankings. And I can certainly send you the presentation that I did for that will demonstrate it. And we'll talk about some of that methodology in just a little bit here. But in terms of how the rankings come out, then once all these measures are considered and the rankings are calculated, then again, there are two separate rankings that are given for every county in the U.S. And here's the map of Kansas. And there's, again, a separate health outcome ranking and one for health factors. And the map just breaks them up into quartiles. So the lighter colors are those that are ranked the highest or the most healthy is one way to look at it. And the darker ones are those that are ranked the lowest. For 2021, Shawnee County ranked 64 for health outcomes and 47th for health factors. And one thing that we always like to emphasize that it really is important to go beyond the rankings themselves or to go beyond the snapshot. And there are several reasons for that. One reason is because rankings can vary quite a bit over the years. And this, I've got a couple of graphs here. One, this is just showing how the rankings have varied over time for health outcomes for Shawnee County. And you can kind of see how much they go up and down. And then this is for the health factors, and you see it's even more variable in some ways. And so why is it we see so much variability in these rankings over time in a community? I think it's important to remember that the rankings are based on a relative position for a county. And so things like random statistical error based on some of the data sources that are used for the measures, such as survey data and other things, can just have some general variability and so forth. I also mentioned the weighting that's applied to those. So even small changes in the measure values can result in big moves, either within the county or, again, because rankings are relative, it also depends on what's going on in the other counties. So if there are changes in the other counties, that'll change your county's rankings. So it's important to keep that in mind. For 2021, I just want to make a few technical notes on the county health rankings model and the measures. You'll notice on the fact sheet that we produced that there are a lot of empty cells for the data over time, and that's because there were several changes. First of all, to the BRFSS measures, that's the Behavioral Risk Factor Surveillance System. So that's a survey, a telephone survey of adults in the US and in Kansas. And they adjusted the methodology for that. And then also all those measures are now age adjusted. And so they're not comparable to prior years. There's also a new measure for high school completion. Previously, the measure was based on high school graduation rate, and the national team decided to use the American Community Survey data on high school completion. And it's essentially the percentage of adults ages 25 and over that have a high school diploma or equivalent. So that's a new measure this year. So that's why you don't see the data for prior years on that one. And then finally, children in single parent households measure. There were some methodology changes the American Community Survey made to that. So again, it's not comparable to prior years. So just keep that in mind. One of the things that we do, and you'll notice on the back page of the profile report that we do, is we calculate what we call drivers. Now, this is not something that the national team does. This is something that we do here at KHI. And what we do is we look for the measures and what their impact is on the ranking overall. Now, for health outcomes, again, there are only 5 measures. And so we simply calculate whether or not the value for that particular measure positively contributed to a county's ranking or negatively contributed to a county's ranking. And you can kind of see the trends here over time. And again, there's some variability here. For 2021, the 2 measures that contributed negatively to Shawnee County were premature death, which is the years of potential life loss rate, and low birth weight. And so I'm going to talk about these in a little bit of detail. First, the years of potential life loss rate. And so this is the trend over time. This is one, fortunately, that is actually available for many years now, for a couple of decades at least. And you can see the trend for Shawnee County, which is in the kind of the dark red line with the circles here. Generally speaking, the rate in Shawnee County has been higher than Kansas, as well as the U.S. as a whole. But back sometime around 2014, 2015, there was a substantial increase in that rate for Shawnee County. For the 2021 rankings, it's based on 2017 to 2019 data. So what you're seeing here is a 3-year rolling average. And just to give you some perspective of the magnitude of the difference here, the rate was 8,864 for Shawnee County, whereas Kansas overall was 7,079. And the ranking for Shawnee County here was 82 out of the 105 counties. This represents an increase of about 15.5% since the 20 to 13, 15 data. It's my understanding that Dr. Brazzino might talk about this a little bit, but this has been looked at in the past in terms of what the contributions are. I think it's important to note that the years of potential life loss is really a measure of what's happening with the younger population. So it adds up all the years with deaths that occur prior to age 75. So when you have deaths that are more deaths in younger people, that's going to drive that rate up. We also know that there are significant disparities with the years of potential life loss rate. And again, this is just for Shawnee County. And you can see that the rates for American Indian and Alaska Native, as well as for Blacks in Shawnee County, is at least twice as high as it is for whites and Hispanics. For the health factors drivers for 2021, again, these are the 5 factors, the 5 measures that had the most impact on the rankings, either positively or negatively. In terms of negative impacts, those 2 are sexually transmitted infections, which is essentially the rate of chlamydia cases per 100,000 population, and then the unemployment rate, which was the percentage of population age 16 over that are unemployed but are also seeking work. So I'm just going to go into looking at these in just a little bit. Again, looking at the trend for Shawnee County. This goes back to 2007. Again, Shawnee County rates being somewhat higher than Kansas and a little bit higher than the US, particularly starting in about 2013. But again, between 2016 and 2018, the rate of chlamydia increased by a rate of about 43.5%. So there might be several reasons for this. It could be that there's increase in testing or screening going on. I actually don't know if there's any been efforts to do that, but that'd be something to take a look at as well. And unemployment rate in Shawnee County, again, this only goes through 2019, and you can kind of see how this has kind of gone up and down here. It's the Shawnee County rate is very similar to Kansas. Shawnee County being 3.3% and Kansas being 3.2%. The rate in the U.S. as a whole was 4% in 2019. I did take a look at the most recent data available. For March of 2021, Shawnee County rate was 3.6%. So this is from the Kansas Department of Labor. And again, Kansas was about 3.7%. In April 2021, which is the most recent data available for the US as a whole, is about 6.1%. So you'll see a note here at the top of the screen that in recent years, the trend has improved. So that's maybe some encouraging news for you. The other thing I want to show you is, if you're not familiar with the National County Health Ranking site, is a way to go into the site, and there's a feature called Areas to Explore and Areas of Strength. And that's, you'll see right in the middle of the page there. If you go to the County Health Ranking site, you can click on those two little boxes and it will highlight various measures as either being an area of strength or an area to explore that are colored there. And in 2021, I'm just going to highlight a few things around the areas to explore. For Shawnee County, these were adult smoking, adult obesity. We've already talked about sexually transmitted infections, and then finally, violent crime. So first, I'm going to focus on adult obesity because the smoking data, again, the BRFSS measure for that one, the methodology changed. And so it's not directly comparable from year to year, but I wanted to just take a look at the obesity rate. So in 2016 to 2018, which is the most recent year of data available, the prevalence was 37% among adults. And in 2011 to 2013, the prevalence was 32%. So again, this represents about a 15.6% increase over time. And then finally, here's a look at the violent crime rate. There was no data available for 2015, but again, Shawnee County, the rate here is substantially higher than the US and for Kansas as a whole. So that's just a little bit of snippet. I know that you all are going to have a great conversation about this information and what it means for your community. The last thing I want to do is just highlight a couple of other data sources. I've only scratched the surface even on the county health rankings. And so I'd encourage you to go to the site and take a deeper look at the information that's available there, as well as a couple of other resources, one being Kansas Health Matters. And you can see the link at the below the picture on the left side here. And then the Kansas Information for Communities, which is hosted by Kansas Department of Health and Environment. Both of these sites will allow you to go in and really dig in deeper to some of this information. If you know, say you're interested in a particular topic that the Kansas or the county health rankings has on there, you can go to Kansas Health Matters or to KIC, and you can dig in a little deeper and get more detailed information, say on age groups or on race and ethnicity, and also data over time. So that's the last of my remarks. I'm going to stop there, and I don't know if there's time for a couple of questions I'd be happy to ask, or we can do that later on.
Thanks for that, Charlie. We will have some questions later, and we'll make sure that folks are able to ask you those as we make our way through. We appreciate the overview. But for many of us who don't sort of live and breathe in the work of public health in particular, we are certainly in need of some interpretation. And so thanks for all of that, Charlie. I want to introduce our next presenter for today, Dr. Erin Locke. Dr. Locke serves as the health officer for Shawnee County. And during her first 4 months, she spent the majority of her time working on COVID-19 response and recovery. And we're excited to have her here with us today to share with us the impacts of COVID-19, the impacts that they've had on the community over the past 14 months. And so I will hand it over to you, Dr. Locke. We look forward to you sharing with us today.
Thank you. Can you hear me?
Yes.
Okay, great. I've lost my mouse, so I wasn't going to be able to do anything about it anyway. Well, good morning, everyone. Thank you for joining us today. I'm really pleased to be able to speak about the health impacts of COVID-19. If you're thinking, as I did, that this is a very broad topic, you would be right. It's very broad. And so we're going to cover a lot of ground, and I'm going to go rather quickly through it. We all know that the pandemic started about 14 months ago, and since then it has really upended all of our lives. We can anticipate that the social determinants of health, really none of them have escaped the pandemic and having some sort of impact or effect. What I would like to point out is that our county health rankings that we're reviewing today actually do not contain any data from 2020 or for the pandemic. It will be 2019 and before. But we do, and in fact, a lot of the data sets and other sources of information, it's going to take us years to really gather that and analyze that. But what we do have today that we can look at are some of the real-time research and polling and surveys that were occurring throughout this past pandemic. And so we'll take a look there. Now, no talk about the pandemic would be complete if I didn't, or if we didn't acknowledge that there was a significant loss of life from COVID-19. And in fact, in the United States, it's estimated to be the third leading cause of death in 2020. Now, this death was not proportional. There were certain groups of people who were impacted much more than others. And we know that older adults, people of color, men, they all had higher rates of death and have had. Let's see. Oh, I'm not able to advance my slide, sorry. There we go. So in Shawnee County, when we look at cases and deaths, it's pretty comparable to the United States. We are seeing the same disproportionate trends. Our case rate is approximately the same as the greater country, but our death rate is actually just a little bit higher. I would like to point out that nearly half of the deaths in our community occurred in long-term care facilities, particularly in the fall and winter. And this really reflects that was a time when we had such wide community spread. It was really uncontrolled. We were no longer able to protect the vulnerable in these facilities. Now, there's been a lot of attention on our health system and our hospitals during this time. And one might think that because they were so busy and frequently overwhelmed, that from a financial standpoint, they've been doing quite well, but that's actually not the case. We can all recall that back in the beginning, our sort of the high earning procedures, those surgeries and things had to be canceled and delayed and are still trying to be caught up. But at the same time, there were so many purchases that needed to be made for PPE, construction that needed to be done, investments in telemedicine. And all of this was done with competition amongst each other for very limited resources. So that has led to a significant financial strain on the healthcare system as a whole, with billions of lost revenue. But the people who work in those systems have also been impacted. We know that many have been working extremely long hours. They've been understaffed, isolated, at personal risk. And then when they go home, they have also dealt with stigma and threats. And we've seen that here in Kansas, we've had many of our health officials, in fact, resign or retire. But not just the burnout or the financial strain, our healthcare workers have been on the front lines and are estimated to be 3 times more likely to have contracted COVID. But even this has not been proportional. When you look at who of our healthcare workers have died, 2/3 have been people of color. There's a higher rate of young people dying amongst our healthcare workers. And in particular, you're more likely to die if you work as a nurse or support staff, or if you work in a nursing home. So with the strain on our healthcare system, that's led to significant delayed care for our general population. And last summer, 1/4 of US adults reported that they had had delayed care because of the pandemic. It was even higher in Kansas at 40%. And even now in the spring of 2021, 20% of adults reported delayed care in the last 4 weeks as a result of the pandemic. And there's a lot of downstream consequences from delaying care, but a couple that have been already researched in these last months. Our national cancer screening rates have declined, as have our sexually transmitted disease screening rates. We know these diseases didn't go away. We just have not been able to identify and treat them. Also connected to the healthcare system was an expectation that with job loss, individuals were going to lose their health insurance. And actually, this has been looked at by the census with their household pulse survey and then further analyzed by the Kansas Health Institute. And this was more like the last look was in the fall of 2020. What's surprising is that the uninsured rate nationally has remained relatively stable and has perhaps slightly increased in Kansas. And this may be because individuals who lost their jobs were not insured through their or through their employer anyway. But there's going to need to be ongoing look at this topic. Speaking of unemployment, I know Charlie has already mentioned it, and I agree with you. We got our data from the same source. Our current unemployment in Shawnee County is 3.6%, but it did spike as high as 12.4% last April. And in that same household pulse survey conducted by the census, a third of Kansas adults last summer reported expected loss of income in their household. So when you lose your jobs and you lose your income, that means that it makes it more difficult just to have your basic needs met. And one of those basic needs has been food. The national organization Feeding America, they estimated that about 14% of Americans did not have enough to eat last year. And an additional national organization, Meals on Wheels, they reported that most of their programs experienced doubling of demand for Meals on Wheels services. Here in Shawnee County, Feeding America estimates that our food insecurity increased by 20%. And you can see a couple other statistics for Kansas as well. It is not proportional, the need for food. Along with food, there's the need for housing. And in the US Census survey this spring, a third of adults in Kansas reported that they were at risk for eviction. We know that the program that was in place last year served over 27,000 residents. We currently have a moratorium in place, but that is set to expire at the end of this month. And while I don't have any current data for Shawnee County, it's important for us to keep in mind that according to Princeton's eviction lab, prior to the pandemic, our eviction rate in Shawnee County was higher than both state and US averages. Now, the next two slides, I'm going to touch just briefly on education and childcare, which we have all learned has been so interlinked. And there's a lot that can be said about education, and I'm no expert in this area, but there's a couple concerns that I wanted to point out here. The first is decreasing enrollment. We know that preschool enrollment dropped in the fall of 2020, and on the other end of the age, we know that college enrollment also dropped. But even for those students who are still in school, there's been such disruption in their learning that much of their learning remains unfinished. And we know that this, again, is not proportional. And in particular, if you are low income or a person of color, you are more likely to be impacted by this disruption in schooling. Childcare has also played an important role for all of us during this time. And the US Chamber of Commerce reported that 2/3 of working parents had to change their childcare arrangements. And in fact, there are some parents who did not return to work at all, citing childcare as the reason. And I just wanted to make note that childcare is an important small business for our economy. Many of them are run by women and women of color, and they have had a lot of stress placed on them during this time as they are not able to take in as many kids, so their revenue has been decreased, but the cost of operating their businesses has soared with all of the need for PPE and other measures. So all of this leads to mental health concerns, of course. When we look at the United States, and a similar trend has been found in Kansas, about 40% of adults have reported some symptoms of anxiety or depression during this pandemic. And that holds true for young people as well as essential workers. And what we are finding is that individuals with fewer resources are more likely to have symptoms, which makes sense. If you're someone who's lost their job, if you're someone who doesn't have much income to begin with and you don't have as much cushion, if you're a woman with children or people of color, we're seeing increased symptoms for those groups. There's some data about some of the downstream effects of mental health concerns, and we know that drug overdose deaths and homicides increased in 2020. Now, a surprising but happy thing to report is that we actually saw a decrease in suicide deaths. And there's still some look into why that is, and we don't know what 2021 will bring, but in 2020, suicide deaths actually decreased. Okay, and so one of my last slides here is that when people are stressed, we often resort to behaviors that help us cope, but may not actually help our health in the long term. And we know that alcohol sales and cigarette sales both increased in 2020. On some studies, adults reported that they were drinking alcohol more often, and when they were drinking more of it. The Quit Now hotline reported that the calls of people seeking to quit smoking in 2020 decreased by 27%. So that is, of course, very concerning. And when we look at physical activity, many studies across all age groups recognize that at least early in the pandemic, when many of us were in lockdown, our activity decreased. And this may be associated with poor eating habits as well and weight gain. And so those are just a few of the health behavior consequences. Now, that was all kind of heavy, what I was talking about, and I recognize that. When we look at the pandemic, there's going to be more to its legacy than just negative memories and historical documentation. We actually can look at some positives that have come from this pandemic. When I talk about families and businesses and communities struggling, we saw our Congress come together and enact large relief plans to help all of us stay afloat. We saw unprecedented vaccine development and investment in our infrastructure. And one that's very important to me is that we recognize and have begun discussing very clearly the racial and ethnic disparities that have led to these unequal outcomes in our health. And another one that's very important to me are the community partnerships that have been formed during this time. Very unique and innovative partnerships have sprung up as we've all been working together to get through this pandemic. So that really leads me to my call to action. You know, today, here working on our community health assessment, we're very diverse. We come from many aspects of our society. We all have very different backgrounds, and we are strong in that. And we are strong in the partnerships that we have formed and that we intend to form. And so my call and my ask is that each of us identify where we fit and what we can contribute, and that we continue our partnerships and our collaboration so that all of us together can form a healthy and equitable Shawnee. And so that will really finish my talk. I have a lot of references. So if anyone is interested in taking a look, I'm happy to have you take a look at those references. Okay. Back to you.
Excellent. Thank you so much, Dr. Locke. And as we mentioned, we will have the slide decks available. So thank you so much for the information there. Obviously, many of us know about the effects of COVID. What many of us may not have known is how widespread. And so thank you for the research and the opportunity for us to see those, particularly in a number of different sectors. At this time, we want to provide an opportunity for a panel of local experts to talk with us about these findings, also about COVID, and to help us better understand our local situation here in Shawnee County. And so we want to invite, along with Dr. Locke, we want to invite two more strong community health advocates. The first is Dr. Gianfranco Pizzino, Senior Fellow and Strategy Team Leader with the Kansas Health Institute, and also former Shawnee County Health Officer. Along with Dr. Pizzino, we want to welcome Dr. Rita Stanley, a board-certified internist who operates a private practice in functional medicine here in Topeka. So Dr. Pizzino, Dr. Stanley, and Dr. Locke, thanks again for being a part and joining us today. I want to give each of you an opportunity to give you about 2 minutes to give some initial reflection and response to the presentations and to what we've heard today. So we'll start with Dr. Pizzino for 2 minutes, and then we'll have Dr. Stanley, and then we'll have Dr. Locke. So I want to give you an opportunity to share. So Dr. Pizzino.
Thank you, Brett. Good afternoon, I guess, everybody. Last time I talked about the county health rankings was in 2019 in front of a crowd at the Topeka Library, and I remember that was a very productive and interesting conversation. So I hope that we will be able to do something similar today. I have a few thoughts that I would like to share with you. And we have heard about two things that are seemingly not very closely related. One is the county rankings around social factors that affect health and many conditions that are actually long-term conditions, years of productive life loss and so on. And the other is a much more immediate and current acute issue, which is the pandemic. And the first point I would like to make is that these two are actually not as disjunct as they may appear, because the pandemic didn't come in a vacuum. The pandemic is taking place on top of all those other factors and social dynamics and all those elements in our society that affect our health in general. So pandemic is not in disjunct from everything else that happens around health. And along that line, I want to make three main points. The first one is that we should never forget that the pandemic is not an equal opportunity occurrence, just like other diseases are not an equal opportunity occurrence. You heard from Dr. Locke, you heard from Charlie Hunt, the wide disparities that exist, how differently different groups of people in our society are affected by those elements. And the pandemic is just like everything else. Just like in a more traditional, so to speak, conditions like diabetes or heart disease, some people are disproportionately affected by the virus because they live in conditions that increase the risk of infection or severe disease. And guess what? Those conditions are not very different from the same conditions that will increase the risk of, say, diabetes or heart disease. Housing, poor nutrition, poverty, uninsurance, those are the same factors that drive our county health ranking. And they also affect how people are impacted by the virus. People do not have the same opportunity to stay healthy, both when it comes to extending their lifespan and preventing their diabetes, and when it comes to preventing the virus. Not everybody had the luxury that myself and many people probably around this circle had of spending many months at home, working from home in a safe environment. We should never forget that the people who went to work during the period are those who actually suffer the most severe consequences. And that's just an example. So when I hear we are in this all together, I think we are at some level, in the sense that the health of each of us affects the health of everyone else. But it's also a somewhat misleading statement. We should not forget that some people are navigating the pandemic storm on a luxury yacht, while others could barely afford an unstable raft to float and to stay afloat. My second point is that we all want to go back to our normal. And I often hear the term of resilience. We have a lot of resilience. That's an asset that we need to use. But when I look up the definition of resilience, it's defined as an ability to recover from or adjust easily to a misfortune or a change and return to the previous status before the stressor. And that second point I want to make is that we are not here to go back to where we were before. We must do better than that. Going back to the same status as before is not acceptable, because it will just perpetuate decades of injustice and disparities in health and in the factors that make us healthy and resilient. So the new normal really must be new. We cannot go back to the same situation where we were before. And I think we have a great opportunity to make some structural changes right now. because of all the attention around these issues that the pandemic has brought. And then my third and final point is that responding to a pandemic from a virus and to a pandemic of health inequity and injustice have many things in common. And one of the things, for example, we always want to use prevention and mitigation. And what's the main prevention item that we have against a pandemic? Everybody knows it's a vaccine, right? And it's highly effective, and we all want to develop the herd immunity where we have enough people protected that in turn that will protect everyone else. Unfortunately, we do not have anything we can inject. It can be produced by a manufacturer, a drug manufacturer, like a vaccine against a pandemic. But I'm here to argue that we do have vaccines that can take care of that inequity, and that's called policy. We have policy changes that we can enact that will remove the conditions that make some of us more vulnerable to adverse health effects than others. And those includes policies that can address social justice, reduction of wealth inequality, housing, access to healthy food, education, poverty. That's the real vaccine that we have to eliminate the health disparities that are in our community, the same that Charlie Hunt and Dr. Locke described to you a few moments ago. And that will create herd immunity, just like it does for the vaccine against the virus. Because when most of us are protected, then we will be better able to take care of the few of us that still struggle and need some help to develop the same kind of resistance that we all have, that the rest of us have. So both when fighting against the virus and when addressing those root causes of health, we need to remember that we are only as strong as the weakest link in the chain. And that we need to take care of those weak links in order for all of us to become stronger. Those are my thoughts, and I'll be happy to hear yours later on.
Excellent. Thank you, Dr. Pizzino. Dr. Stanley.
Sure. Well, listen, thank you for having me here. And, you know, I see that we have a great opportunity in this community and in this county to really, as Dr. Pizzino said, do the work and make some changes that are going to affect future. Well, we want to get people healthy anyway. And so I'm coming from the perspective of a practicing physician, boots on the ground. And what I know is after 35 years of practicing, I keep coming around full circle to what I consider the main thing, which is food, the quality of our food, access to food, and making sure that people across the board, no matter what the color, what the economic status, have access to good, healthy food. You know, what has become clear during this pandemic is certainly there was great disparity in how people survived or got sick, and people of color got much sicker and died more often. And it was for a reason. There's really nothing new under the sun. We already knew that certain groups of people had greater incidence of diabetes and obesity and cardiovascular disease. From a functional medicine status, because I've been on both sides. I'm trained traditionally. I learned how to diagnose and treat. I've also trained in functional medicine where we ask the question, why? Why do so many people have diabetes, high blood pressure, heart disease? And what I know from a functional medicine standpoint is that way before the pandemic, people had a lot of inflammation in their body. They had vitamin D deficiency. They had other deficiencies that were not corrected. They were treated, but not really given people weren't given the opportunity to make changes in their lifestyle. So when COVID came on, then, well, it just had good ground to just wreak havoc, and that's what it did. So I guess my first point is, I've had the opportunity in the last 15 years to see people who start out with deficiencies that have been identified, to do something about it. And that means a great deal of education. And it also means a great deal of access to good food, not just any kind of food. And I can tell you, food makes the difference. I cannot tell you how many people I've been able to help with diabetes, for instance, who reversed their diabetes. Their A1Cs were below 5 with food. And if it sounds simple, I don't mean to simplify it, because we know access to food and hunger is one of those social determinants that just seems to be difficult for us to make any advances. But it takes effort. And when you have hunger and people are not able to get to good food, then we are never going to see improvements in those underlying conditions that make people more prone to early death. And I'll say this to you, it's not just high blood pressure, diabetes, and heart disease. I'm talking about children who don't get adequate food. Their brain does not get adequate nutrients. They cannot learn. There are neuroscientists who also have shown the association of poor nutrition and violence. So from my perspective, and my life, the rest of my life is devoted to helping people understand the importance of good nutritional food. I don't know how much I'll get involved at a higher level of policy, but there is a great deal of work that needs to be done at the policy level around the types of food that we allow in our schools, the marketing of food to poor communities. And so the rest of my life will be devoted to that. I spent a lot of the time over the pandemic helping people understand the things that they could do that might reduce their risk of severe infection. And that was around optimizing your vitamin D level. That was around lowering the amount of carbs in their diet. And I know you're saying, well, people are too poor to do that. I don't think like that. I believe if you give people information, if you help direct them to ways they can get things, what I have seen over 15 years of functional medicine is they will do their best to do that. And so people during this pandemic, they got on their vitamin D3. And frankly, the science supported. You can go out on the internet and you can see now that through the pandemic, the people who did the worst were vitamin D deficient. The people who did not do as well, including people of color, were people who started out with inflammation in their body. Then they got infected. And listen, the response to infection is an inflammatory response. So if you're already inflamed, you get infected, then your body goes into a dysregulation. And that's why so many people died from COVID infection. So my point is, food is in my mind, our chronic disease and health epidemic is a food issue. And food is the biggest driver of health. And so I'll leave you with this. To me, the greatest way to make headway in this food issue is at a community level. There are policy-based things that have to happen, but there are so many things that we can do together as a community to work toward this food injustice, because food insecurity is an injustice. It's part of the racism that we have to confront in this country and in this county. So if we come together as a community, we've got K-State, which is an agricultural university. There are ways we can teach people how to raise their own food. We can teach them the impact of what they put in their mouths. We can work on getting access to grown, good, healthy food, even in the biggest food deserts in the food deserts in this community. So we have to work together. It's gonna take some hard work, but it's doable. But we have to get back to a place where food is accessible. We have good quality food that is grown in our backyards or in our community. And I'm convinced that before I leave this place, I will see numbers. I will see incidents of diabetes and high blood pressure and heart disease and kids who can't learn. All of those things are going to improve. but it's really up to us. And the whole, it's around good quality food. Thank you all.
Thank you, Dr. Stanley. Dr. Locke, want to give you an opportunity to respond.
Oh, sure. I will keep it very brief so we can stay on time. But man, I was hearing a call to action from Dr. Stanley, and that makes me very, very excited. I want to help you with that, Dr. Stanley. And I hope many people in this room want to help you as well. I think just one thought that I had, and then you've already heard from me, is I really want to emphasize that that we need to think broadly about health. We know food, we know shelter, we know employment, we know childcare, we know schooling. All of these things contribute to our health. And it's not just one person going to see their doctor and that's going to finish it. As Dr. Stanley said, as I can attest to, what happens in someone's life outside the walls of the doctor's office is frequently far more important for their overall health. So we need to be creative and recognize that all aspects of our society are ultimately funneling into our health status, and really place health at the priority. But that means everyone can work to improve health in their individual, niches, I guess. So that's all I'm going to say. So we can keep rolling.
Dr. Locke, that's great. Dr. Stanley, Dr. Bazzino, thank you so much. What great segues. We have heard certainly multiple calls to action from our panelists and our speakers today, opportunities for us to be able to get involved. And so that's exactly what we're going to do. That's exactly what we're going to do here. So we're getting to this part of the meeting. We're getting to this part of the day where we look to all of you. We look to you for that participation. We look for you to respond. We look for you to think about that niche, about that space where you may be able to get involved. And so at this time, I want to introduce Austin Jackson. He's the Director of Strategy for Stormont Vail Health. Austin is going to walk us through a quick review of the data from the Community Health Needs Assessment conducted earlier this year. And then he's going to engage all of you in a priority setting exercise to help ensure the best prioritization of health needs in Shawnee County. So Austin, thanks for sharing with us today.
Thanks, Brett. Can you hear me okay?
We can.
Great. So I don't know how exactly to follow up Dr. Bazzino, Dr. Stanley, and Dr. Locke after those wonderful comments, but I will do my best to not bog the meeting down in data. I have put in the chat box a link to a Poll Everywhere site, because we will be looking for some interactivity through these segments. But as Brett said, I'm Austin Jackson. I'm the Director of Strategy and Business Development at Stormont Vail, and I get the good fortune and great purpose of working on our Community Health Needs Assessment. So many of you on the meeting and others have given feedback in terms of a survey that you guys saw from February into March, as well as many community roundtables. I think we did upwards into 15 or 16 of those community roundtables where we talked about the issues that you've heard raised today. So I wanted to spend a brief amount of time just showing you where we've been, starting from our last survey to this one, some brief introduction to what you guys told us, and then spend the rest of the time listening to you all again and making sure that we're pointing the ship in the right direction. So first thing I wanted to show you from 2018, this was the last time that we engaged in the Community Health Needs Assessment. And here were the 4 priority areas that were identified. We talked about mental health services, safe access to food, substance abuse, and health equity. And so we went through the process of surveying like we did last time. We gathered all that data. We had great response from the community. So we did that again in 2021. And this is where we'll go into that first poll question. But here is the list of priorities that you guys told us were important. And many of these will look familiar, but I wanted to take a minute, if you all would go out to that website that I showed you, and answer that first poll question. Take a look about 30 seconds through the list of priorities. And does this list match your perception of our community needs? Is this what you think are the needs of our community? So again, I'll give you just a few seconds to get out there and respond. You can see that as responses are coming in, we're about at 80-20. Yes, we do feel like that's a representative list that I just covered up. Anyway. Just a few more seconds. Okay, great. All right, we're gonna go ahead and stop that one there. So as you guys can see, 92% on the call agreed, said that this list seems to represent what your perception is of the needs of our community. So as we look through, number 1 and 2 were by far and away the most chosen options: affordable health insurance and mental health access. And then we kind of had the other ones come in, so poverty, obesity, some of the things that you've heard about today. Now I want to take a second and make sure that we're not missing anything, right? You can come into a meeting and think you know based on survey results, but there's always something missing. So if you go back out to that poll link, just type in, what do you feel is missing from the list? What haven't we captured in the data that we've already taken from you? And let me know if it's not working, but.
Austin, as those are coming in, we did have a question about the number in the first poll.
Yeah, absolutely. First poll, or the one we did in 2018, we had 2,200 responses. In this iteration, we had 2,500, almost 2,600 responses. So we did see even more folks giving their feedback.
Excellent, thank you.
All right, we'll take a few more seconds to let those things come, to let you talk about what's missing. I see housing. Sure housing is probably what's going on there. We got health, prenatal. Yeah, keep those coming in. These are great. What else is missing from this list that you would like to make sure that we capture? Okay, I'm gonna go ahead and stop it there. So what strikes me about this list is housing, of course, affordable housing, number 1. Does anyone on the chat want to chime in and talk about what you meant by that? Open for comments there.
Hello, this is Cameron.
Hi, Cameron.
I would say a disparity between the amount of money that individuals that have for their budget for housing is pretty small compared to what the national or the county average may be for that budgeting for housing.
Okay, so you're looking at housing as the line item on the budget, and there's just not enough money in the month to afford our housing. Okay, thank you for your comments, Cameron.
You're welcome.
Okay, I do see disparity that we'll talk about. Is there anything else that anyone on the call wanted to call out? I'll give it just a couple of seconds for more comments.
This is Miriam from Topeka Rescue Mission. I would just add on to what Cameron said about housing. It's not just about affordable housing, it's about decent, safe, affordable housing. So I think it's important to have those other words, because there is affordable housing, but not where it would provide any sort of quality of life or an opportunity for people to feel like they're actually in a place where they can be healthy and safe and raise their families.
Thank you, Miriam. Okay. Do want to stay on time, so we are recording these responses, and we'll include in the follow-up some of these things that came up outside of the polls. So thank you for those responses. Now, what we've went through so far is you've told me as a community you feel like this list, along with the things that you've added here in this word cloud, represent our community needs. So the question next is, we can't work on all of them all at once, right? So how do we prioritize? What is the way that we go about identifying what work needs to be done first, not necessarily what work needs to be done? So what we did in the survey itself, we asked you all to rank each of the problems that you've identified as, is it a very big problem? Is it not a big problem? We also asked you to detail your perception of community services. That's this middle column here on the table. And then we asked you to talk about the quality of those services. So this was in an effort to begin to prioritize which problem needs to be addressed first. And so what I do want to note that we're not going to solve anything today. We don't want to identify necessarily solutions today. Today is the first step towards identifying the problems to work on. And so I want to take a minute and talk you through how we prioritized and then what came out of it. So we looked for responses for more than 30% of respondents that identified something as a very big problem. We also looked for those, more than 5% of the community that identified no services for the identified issue, and then 10% or greater of the quality being unacceptable. And when we looked at our data, we identified which of these topics have more than one of these three categories captured. Two or more, either very big problem, no services, quality unacceptable. And I've highlighted those here on the screen. But what rose to the surface for me was 4 major areas of work based on the priorities that you gave. One was access to mental health services, to healthy eating and obesity. I put those together. I know that they're separate and distinct, but there is a connection. Substance abuse, and then 4, just call it equitable access. There were a number of issues that you all identified in the survey, whether it's through knowledge of the available service, transportation to the service, or other ways that you have identified those being important. These were the 4 kind of major areas that rose to the surface. And I'm going to flip back and have you look at our prior areas, and you'll notice that it's pretty much almost the same. The same areas have risen again. And what I'll say about that is, to Dr. Locke's point before, COVID shone a light on the inequities and shone a light on the things that we really need to work on. So I think that's what I'm hearing from you all as a community from these survey results. We knew these were areas of work that were needed before, but now they have completely risen to the surface, and we've identified new factors within these areas. So by show of thumbs up or thumbs down in the chat, do you guys tend to agree with those 4 areas, or were there things that we're missing? And I'll stop here for comments or feedback. I see some thumbs up. Excellent. I don't see any virtual tomatoes being thrown, so I must not be too far off. See, agree. Okay. So let those responses keep coming in. Looking at these 4 areas, this is where I want to spend the bulk of my time. We've heard what you've said here about being a very, Alyssa, agree, more people outside of health see the issues now after COVID. Completely agree. I want to dive into each of these 4 areas individually. And my background at Stormont Vail has been in process improvement, fixing problems has been my background. And so the first thing you need to do to fix the problem is really identify what's driving it. So what are the key factors that we need to know about these issues? So if you go again out to the poll, you should be seeing what are the top 3 issues leading to our problems with mental health access. And I've identified here on the screen, this one to me was number 1 for the reason of it was identified by most of you as a very big problem. And more than 1 in 4 of you identified it as being quality unacceptable. So go ahead, I'll give you about 30 seconds. Type your information into the poll and we'll see what rises to the top. Let me check to make sure there are there any questions in chat, Brett or Craig?
I don't see any.
Okay. Okay, we'll take a few more seconds to get those responses in. Okay, I'm going to go ahead and close it. And let's see what came out. So there are top answers: too expensive or cost. I'm going to go ahead and put those together. Accessibility, capacity, no free services, access, cost. So I'm seeing a trend here kind of from the beginning of today and into now. We talk about access. So can someone who put in accessibility or capacity go ahead and unmute and tell us what you mean by that? Anyone who wants to weigh in here?
Hi, this is Miriam. I would say when I'm thinking about accessibility and capacity, it really kind of goes together in terms of if I'm living on the street, how do I really access services if I don't have access to people that know how to get me there? And all of the challenges that come with that. So speaking from that perspective, but it's just kind of knowing what's available, being able to get in and having enough providers out there to be able to address all of the different and varying needs that go into mental health issues, which includes addiction and all of the above.
Thank you. Scrolling
Austin,
through.
this is Brett.
Go, Brett.
I had something very similar to Miriam related to capacity, related to essentially number of providers. In these conversations, we've talked a lot with different groups who have been around a long time, talking about the long-term effects of menagers leaving the community, and in particular, the disproportionate amount of our population who have mental health needs. And so when I think about capacity that way, I think about the great providers that we have here who are doing great work, but I also recognize that there's limited capacity there with experts, caseworkers, et cetera.
Thanks, Brett. Other comments or questions that we want to raise around the area of mental health access? You see in the survey data, there was a number of responses related to health insurance. So I think that would go in here with the cost and too expensive as well.
Yeah, it looks like we've got in the chat, Austin, some conversations about that in terms of insurance being a hindrance, but also being to difficult to navigate and difficult to understand.
Okay. So even if you have insurance, being able to find the right provider or get to the right area is the difficulty identified. Okay. Okay. So now we've identified those issues. It matches what you said in your survey. And if nothing else for today, I want to make sure that you all have an opportunity to validate what we've seen in the survey, add new comments as we go through. And I do want to activate one more poll related to mental health services. And it really is what should be done. You know, we talked about what are the issues, but here is where I want you guys to put in what you think should be done. So I'm going to give about 30 seconds and say, thinking about mental health access for our community, what would you like to see in the next 3 years as we work through this community health needs assessment? We'll give another 20 or 30 seconds here. Is it up and working for everybody? So again, if I'm completely honest, this is the first time working with Poll Everywhere, so the fact that nothing's exploded is great.
It's working. It's just a really hard question.
It is, and we want to make sure that we give you time to think about it. But as leaders in the community, we really want to get your ideas down and make sure that we're not thinking. We don't have to think of something you have already thought of. You know what I mean? All right. Okay, I'm going to go ahead and close it right now and look at what we've identified. I see Medicaid expansion as one issue or one opportunity. Destigmatize is one that I want to call out right here. It looks like it had a number of responses. Community programs. If COVID taught us anything, it's that if we get together in a community, we can solve pretty much anything that comes at us or work toward it. Okay. Thank you all for your input there. So knowing mental health access is the #1 priority, we'll take the responses in the survey as well as what we've talked about today and start working at a community level with HHN and others to work on solving these problems. But I want to move into our next one, which is obesity or nutrition. And we heard from Dr. Stanley give some really great remarks around the importance of food, but I'll ask the same question. And it's out at the poll. What are the 3 issues? What do we need to know about our food web in our community that wasn't represented in the survey data? So go on out there and type in what you think, what you're thinking about. Top 3 issues within healthy foods and rising obesity. Give another 10 seconds or so. All right, I'm going to close that there and let's take a look. I think there's a by far and away a winner here. It's food deserts, and we know that through the work and with our Shawnee County Farm and Food Council, accessibility to healthy foods. So as we're thinking about the next 3 years within access to healthy foods, what I'm hearing you all say is, as a community, we should work to bring back grocery stores into those food deserts. Again, just validation of what we've seen in the survey data, as well as getting your feedback here. But I'm interested in buy-in. Can someone tell me, if they feel comfortable, tell me what you mean by buy-in? If not, that's okay. I'm just that's one that piqued my interest there. Just picking through, and it looks like, yeah, again, it's all about where are those food resources located. So as a community, improving our access to healthy foods by closing food deserts. Any other comments around healthy food and obesity that we want to bring up before we move on to the next topic?
Austin, this is Dr. Stanley.
Hi, Dr. Stanley.
I just believe that we have to start early. So utilizing schools, and I'm not sure the status of, when First Lady Obama, she had a program that she really tried to make available in the schools. I'm not sure how successful it is right now, but if we start with educating kids about healthy food and providing healthy food in the schools would go a long way.
Okay, so early education and what are good foods, making it available. Thank you, Dr. Stanley. Other comments here?
I just noticed in the chat, Austin, that Virginia was talking about food swamps, and food swamps and food deserts sort of go hand in hand in her description here of a food swamp being those areas with high density of establishments selling high calorie fast food and junk food relative to healthier options, particularly when we think about the lack of grocery stores.
Absolutely. So at not only the food deserts, but putting not the wrong foods, but the unhealthy food options in what tend to be lower income areas. I assume that's what you mean by that, Virginia.
And the unhealthy options are often less expensive.
Right. Okay. I haven't heard that term food swamps before. That's a new one for me. I like that. Okay, I'm looking through the chat to see if there's anything else we want to pull out. Yeah, so unhealthy options are more shelf stable too. So it sounds like, again, thinking broadly to what Dr. Pizzino said about policy, how can we work at a community level to change some of those factors that are leading to unhealthy food options? So I really like the discussion that's going on in the chat. I want to make sure that we get to the other two topics though. So don't stop putting stuff in the chat, but I'm going to move to the next one, which is substance abuse. We've identified 3 areas: tobacco use, prescription drug dependence, abuse or dependence, and alcohol illegal drug use that really rose to the priority level of the community saying it's a very big problem, as well as the quality is unacceptable. So again, I ask, I'm gonna go out to this tool. What 3 issues do we need to consider here? This is a problem, multi-year problem that we've been looking at for our community. So if you go back out to the poll software, type your top 3. What are the 3 things that we need to spend our time as a community closing to make movement in this area? Give about 30 to 45 seconds to do that. Okay, another 10 seconds or so. They do want to note what somebody wrote on one of them. Why isn't the high STI rate a larger issue? Thank you for raising that. That is something that did not come up in our survey results. But we will make sure to add it into our report as we talk about next steps and things we want to work on as a community. Okay, I'm going to close down that one and see what came up. Okay, I see mental health. So folks tying the number 1 and number 3 issues together. I do like this dual diagnosis identification here. So also healthier alternatives for stress. Seems to be a number of responses in that vein. Can somebody talk about that? What could we work on in the next 3 years in that way? And if not, throw it down in the chat as well. Underlying causes of the increase, yeah. Education begins at home in our community, okay. Okay. I do see this one right here that I want to call out: addiction treated as a disease, not a felony. What I'm hearing you say there is there's a lack of addiction services in Shawnee County. Is that a fair assessment of what you're trying to say there? Okay. I'm seeing in the chat, decriminalize it. Violence is also related to substance abuse, okay. Social media tells me that wine is the answer to all of working mom challenges instead of addressing causes of challenge stress. Okay. Any other comments around substance abuse that haven't been captured here or in the chat?
One thing I think we need to consider for the future, I'm sorry, this is Jane Reacher, is that education, college education is increasing. The cost of it's just getting out of control. And so we're asking people that hold BAs, which will probably cost right around $50,000 to receive, to start a job around $32,000, $35,000 a year, which means it'll take them almost a lifetime to pay back their student loans. So increasingly, we are not getting alcohol and drug counselors. We're not getting social worker, BA social workers, anybody with a BA. It's going to get worse and worse and worse because we're not getting it because it's not worth going that far in debt to what they're getting paid.
Okay. So kind of taking access to mental health services down the education route. So the root cause of it being it's too expensive to become a provider.
Right.
Did I get that right? Okay.
Yeah.
Thank you, Jane. Other comments here? Okay. Again, we've recorded those responses, and in the chat, some great conversation related to rehabilitation should be the focus, not punishment. Absolutely want to make sure that we capture that. Last one is arguably the one that we've talked the most about today, equitable access. So I had initially framed this in terms of healthcare services because that's what the survey was related to. But really what I'm hearing you say as a community is we have a broader issue within access and equity. So I do want you to go out to the survey again. And when we talk about equitable access, I know it's a broad question and difficult to articulate in 30 seconds, but what are we meaning by that? Because we have, from a healthcare perspective here, a couple of things identified, but what is driving, what is leading the problem with equitable access? Go ahead, we'll give another 30 seconds because I think I'm almost out of time here. I do want to capture these last bits of prioritization. Okay, another 20 seconds or so. All right, I'm gonna go ahead and stop it there. Systemic racism, number one. So equitable access driven mostly at the level of communities of color is what I'm hearing there. Poverty is another issue that we've talked about earlier and came up again and again in the survey. So equitable access for those that are unemployed, underemployed, or don't have the means. I see need more Spanish translators, case managers. So working with the demographics of our community, transitioning to provide services to those who need it is what I'm hearing there. And then care expansion, absolutely, I would agree 100%. Anything else we want to add to this before I turn it back over to Brett? Because I did want to make sure that we got through the top 4 and give some fodder for HHN to start their action planning. Other comments here?
I would like to add personal biases on both sides could lead to equitable access to healthcare services.
Okay, so the biases of either side leads to an inability to receive the service you need. Okay, thank you. Other comments here? Okay, that is what I had to share today. I'll just talk a little quickly about next steps before I push it back to Brett. After today, what we'll do is we'll work to publish a community health needs assessment that's based on your feedback that you gave us, not only in the survey, but today and in the roundtables. Any of these things that you feel passionate about and would like to work on, HHN, Heartland Healthy Neighborhoods, has work groups that are dedicated to these topics. So reach out to Brett Martin or anyone on that team to see where you could get plugged in, because this is how we're going to drive change, is at a community level. We'll be looking for October to publish the CHNA report, that's the Community Health Needs Assessment. And then after that, we'll kick off our action planning to figure out how are we going to close the gaps that you all identified in the next 3 years. Thank you all for your time today. And Brett, I'll hand it back to you.
Excellent, Austin. Thanks for all your work on that. And special thanks to everyone for being a part of the conversation here today. As Austin mentioned, one of the great ways to follow up and to be involved with this, you can certainly email me, bmartin@unitedwaytopeka.org. We'll make sure we get that into the chat to learn more about Heartland Healthy Neighborhoods. The first thing I want to do, though, before we wrap here, as we're right at 1 o'clock, is just to say thank you. Thank you to all of the presenters. Thank you not only for the rich conversation and analysis, but also it's very clear that you are passionate about this. And so we are certainly grateful for those who presented to us today, and also individually for the calls to action. Secondly, we want to thank our visual note taker today, Sarah O'Keefe. Thank you so much for capturing the meeting, and we're very excited to see this as part of our health needs assessment. As a reminder, all of our presenter slides will be made available later this week, in addition to the recording and an evaluation that we would ask for you to fill out. This is the first time we've done this virtually, and we want to give you an opportunity to tell us about the process and to evaluate it. We want to make sure that this is the best possible event moving forward, and so we appreciate your feedback. Next, I just want to thank all of the partners. Want to thank Shawnee County Health Department, not only for the work in this process, but also for the hard work, especially over the last 14 months through this pandemic. I want to thank Heartland Healthy Neighborhoods and all of those folks who volunteer as chairs or as work group members who have been doing such a great work to move the health of our community forward, and also to Stormont Vale Health for for all of the work today. A special thanks to Austin for leading us through the prioritization process. Again, if you're interested in being a part of this, bmartin@unitedwaytopeka.org. You can get information from me, and we can figure out where it is that you want to plug in. Stay tuned for more next steps. Thanks again to everyone. We look forward to the collaboration. We look forward to a shared vision, a shared passion to improve the health of everyone in our community. Thanks again. So glad you were here with us. Take care and so long.